My name's Aaron Levo. I'm the Vice President of Communications and Public Affairs. Happy to be with you as always, moderating today's town hall on Thursday, March 24th. Packed agenda full of updates as usual. Just a little housekeeping off the top. If you do have a question, you can email questions to our hhsnews@hhsc.ca inbox, and we'll have that information up for you later in today's presentation. So as you're listening to our presenters, if something comes to mind you'd like to know more about, if you send an email to that email address, we'll be sure to get you an answer very promptly from the experts involved. We'll also have the chance at the end of the presentations today to do some celebrations, as is our custom. So keep in mind throughout the course of the town hall today, if there's something that you'd like to celebrate, someone you'd like to shout out to, maybe a person, a team, something you've seen, something you've experienced, or work that deserves some notice, that would be wonderful to have. So you can do that later by typing it in our chat forum when we open that function. You can also raise your hand and give your shout out live, which is a great thing to do. All right, without further ado, I'll ask our President and CEO, Rob McIsaac, to kick things off. So Rob, over to you.
Thanks very much, Aaron, and good morning, everyone. And thank you, as always, for joining. As we begin, I'd like to acknowledge that we are privileged to provide care on lands that Indigenous peoples have called home for thousands of years. We recognize and respect the presence and stewardship of all Indigenous peoples as keepers of this land. So today, I might start off by pointing out that we're 71 days away from launching EPIC, our new hospital information system. Work on this front has been really accelerating lately, and many of you have begun training. And the opportunities to learn about the EPIC system and how it will change how we work at HHS will only increase in the coming weeks and months. I'd like to point out that the Project Odyssey team has been working so hard to get us all ready for go live on June 4. There's so much work happening behind the scenes by a huge number of people to make this a reality. So my thanks to all of them for all of the good work and all of the hard work that they're engaging in. As I'm sure everyone is aware, earlier this week, the provincial government lifted its masking mandate for most indoor spaces in Ontario. But I expect that most of you realize that simply because masking mandates have been eliminated, it doesn't mean we should throw caution to the wind. I would just implore all of you to please consider wearing a mask, even when it isn't mandatory. Get boosted if you haven't yet. And reduce close contacts. I think collectively our efforts make a big difference in minimizing the spread of COVID in our community and ultimately protecting those who are most vulnerable to the virus. Before I hand it over to Sharon, I'd like to share that our urgent care center reopens today after a temporary closure. My thanks to all the UCC staff who were redeployed to support priority staffing needs across our site. Your flexibility in doing this and your willingness to do it are very much appreciated. So having said all of that, I will turn it over to Sharon Pearson to provide a detailed update on hospital operations and capacity. Sharon?
Great, thank you, Rob, and good morning, everyone, and happy to be here to provide another update on our hospital operations. You can see our COVID numbers on the slide. They've declined significantly. So we have 35 patients today. So recall we were well above 200 at our peak. So that's great news, and a significant decline, less than 5 patients in our ICU, and we have stopped reporting on ECMO. We have not had additional ECMO patients. So again, more good news, and at 0 outbreaks as of today. From a staff isolation perspective, we're sitting at 260, so a little bit higher than we were last week. So a bit of an uptick in those numbers, but aligns a little bit with what we're seeing out in the community and in the province. If we go to the next slide, from an occupancy perspective, unfortunately not such good news. We continue to have pretty significant occupancy pressures. We saw a little bit of a decline and lower occupancy in earlier March, but we were not able to sustain that, so it was quite short-lived. Today, you can see our adult sites, that's live occupancy for the sites, anywhere between 112 and 126%, so very pressured, with Children's Hospital just slightly below at 91%. I mean, ideally, if we could ever be ideal, hospitals should be more in the range of 90%. So we're well above that. We have seen a little bit of a decline in our ALC patient population, which is also good news considering where we're sitting with our occupancy right now. The pressures are primarily driven by a little bit of an uptick in volumes, but also anecdotally hearing about higher acuity coming through our ED departments that's resulting in longer lengths of stay, and also the continued challenge with our home and community partners who are also experiencing quite significant health human resource challenges and capacity issues. If we go to the next slide, we are working very hard on our activity resumption. Of course, we do have the health human resource shortages to manage, and also we always have to be thoughtful in terms of maintaining our capacity for our regional programs and being able to respond to our ED pressures. That said, we've been at 70% of our pre-COVID activity, which is the provincial goal, but by the end of this week, we are targeting to get to 80% after a lot of work. So many thanks to the team, because it has taken a lot of coordination and efforts to make this happen. Good news at West Lincoln in that the operating rooms opened at that site, and we are planning for the return of obstetrics for late April. And as Rob mentioned, we have seen the urgent care reopen, is with modified hours, but again, thanks to that team and would echo Rob's comments. From an ambulatory perspective, we are gradually increasing our in-person visits with ambulatory, of course, continuing to augment with virtual care and focusing on those visits that can support our ramp-up activities and also support more expedited discharge of patients and admission avoidance activities. And then lastly, the deployment, this I hope is my last deployment update. All 312 staff that were deployed have returned to their home units. So again, sincere thanks to that group, because your contributions were essential to us being able to manage through very turbulent times. So thank you very much, and handing it back to Aaron.
Thanks very much for the update today, Sharon. Next up on our agenda is Kirsten Krall, our VP of Quality and Performance and Chief Nursing Executive, to give us an update on visiting guidelines. Kirsten, what do we need to know?
Thanks, Aaron. Good morning, everybody. We did issue some changes this week in our policy for the organization, and it addresses all of our adult and pediatric areas. So the guideline, the actual policy is posted on the library, and we've also issued a short guide, certainly for the adult, and other information will be posted, just because I know people are having difficulty trying to keep all of this all together in one story and in an easy, digestible manner. So look for those materials. They are definitely coming through. But in a nutshell, in our inpatient areas, we allow 2 caregivers, support persons, or visitors at the bedside at any time. The exception to that is our hematology oncology stem cell unit, where the immunocompromised patients are significantly greater. They are asking to stay to the 1 visitor, 1 per day, and only 1 at the bedside. However, we are no longer keeping visitor lists, so those lists don't need to be kept. We aren't doing contact tracing anymore as an organization. Certainly since Omicron came forward, the whole world of testing and so on in public health and in our communities has changed, and so has a little bit of our work as well. So we aren't keeping those lists. Certainly if there was an outbreak and so on, we will certainly be asking questions about visitors who may have been on units with patients and so on, and communication back to those folks. However, we're not keeping these lists for that purpose any longer. So both in the inpatient nor ambulatory are these lists required. And certainly more than last week, even prior to this week, we have also allowed children to be back, so long as they can wear their masks and can follow instructions and have an adult supervising them. They can be back with no particular age restrictions. In the ambulatory emerge and diagnostic imaging areas, this is where we do have a change this week. That has started with allowing 1 essential caregiver or individual with that individual to come to appointments with them. And in the world of pediatrics, certainly the policy continues to have provision that where teams feel it's valuable and important for that patient and the other partner that might be involved with that patient, that they can have up to 2 individuals attend. But we haven't made that a broad brush expectation in the organization, and teams can still use some discretion where that makes the most sense. All of this, of course, is always subject to change as we watch the epidemiology with the virus as well. But this is where we stand today. It is good news from the point of view of loosening these restrictions and really welcoming our families and so on with our patients who are important partners in that care. So one more slide, just a few other highlights I might mention. Certainly our screening work continues at the public entrances, reinforcement of mask use and all the other IPAC essentials. So that's continuing. I was at a huddle this morning with our integrated stroke unit here at the general. Questions coming up about eating and drinking in rooms by our visitors. We certainly are not encouraging that to happen. We would ask that families and so on, leave the premises or, take a break, have a meal somewhere off of our premises. But we do know that we also have essential caregivers that are here for extended periods of time. As an example, pediatrics with parents in particular. But again, we also have individual patients that do have greater needs. Those individuals who are here for extended periods, they do need to eat and drink. When that is described in the policy, and when that does occur, they are expected to stay at the bedside, not move around, have the mask down, curtains drawn so that our staff aren't exposed. And of course, if a staff member comes into the room, they are expected to put that mask back up. So we try and discourage this eating and drinking in rooms, but we do know that for compassion and for the health and well-being of some of our essential caregivers, they need to have that. Outdoor visiting with the nicer weather that is going to be coming, certainly also allowed. We still want people to go through screening. So again, trying to stick to our restrictions, but certainly when they get outside, they can take their masks off. We will always encourage people to keep them on, but for comfort, and again, being outside, it gives people the distancing and the airflow. We're not that sticky about that mask outdoors. Teams always have the discretion around whether or not they want to bend any of the rules around numbers of visitors and so on, and certainly for patients who have compassionate issues, end of life and so on. That discretion is always allowed. And again, even with the outdoor visiting, that's where you would actually say it would be even better to have a few more people if needed to come visit outdoors. Areas in outbreak, we still will manage those situations case by case with our IPAC or infection prevention and control team members giving guidance. But we are now allowing in some outbreak circumstances to allow our visitors to come in. So that is also good news. And our ambulatory areas, certainly where waiting rooms get overwhelmed sometimes. If there is temporary overcrowding plus masking non-compliance, we are leaving teams that discretion also to temporarily restrict that visiting if necessary. So an emerge department, as an example, they really need to identify which zone that is. But just so you know, there is some judgment that is certainly very reasonable in these circumstances that staff can take those measures. All right, back to you, Aaron. Thank you very much.
Yeah, thanks very much, Kirsten. Next up on our agenda is our epidemiology update from Dr. Dominic Mertz, our Medical Director of Infection Prevention and Control. Dominic, of all the forecasts, we need to know what's going on out there. I'm sure you'll shed some light on it and tell us what we can expect.
Yeah, thanks, Aaron. Certainly first starting with the status quo and what we really know, and then we can ask the crystal ball what might be ahead of us. And many of you may have already heard about the models that are out there. First town hall since the beginning that I don't show you any case numbers. And I think I mentioned repeatedly, it's less and less meaningful. Testing criteria have changed. It's only a very small tip of the iceberg that we cover. And with different testing approaches, we cannot compare provinces or nations to each other anymore. So I decided to stop that. And I'm well aware that the narrative out there is we are flying blind because we don't do mass testing. I would disagree with that. For those of us who get more or less daily exposed to COVID issues, we have a very good read of what's happening. Sharon mentioned one of the metrics that gives us a very good idea, which is what percentage of staff is off due to COVID at this point of time. That gives us a great window into COVID activity in the community out there. How many patients with COVID get admitted? And as you've heard from Sharon, it's relatively stable. It might be ticking up slightly at this point. Doesn't matter whether it's because of COVID or with COVID. It's, again, just a reflection of the COVID activity out there. And then for us in IPAC and for those in employee health, we get exposures to newly positive staff and patients on an ongoing basis. And again, just watching that gives us a very good view of what's happening, and similar to in terms of percentage of staff off with COVID, we certainly see an uptick over the last week or two. So those early indicators show that we are getting into the spring wave that I will talk about. And we don't need case numbers, and we don't need to test 10,000s of people every day to get that information. Just as some reassurance for you out there, we know what's happening, and I think we have a very good read of the activity that's happening out there. Eventually you see the outbreak activity, but that's sort of a combination of that pressure of positives from staff and patients into any type of congregate setting. But that's more like an endpoint, that not one of those early indicators that things are picking up again. Okay, let's switch to the data. So no case numbers today, only hospital admissions here, provincial view. You see it's stable over the last 2 weeks, no provincial uptake yet. We are comparable to where we've been in March, beginning of March 2021 or December 2020. We are certainly higher than we've been over summer, which is in contrast to the ICU data that I will show you as well. Next slide. And just more as a reminder in terms of what happened with the change in testing criteria, December 31st, then we went into modified stage 2, January 5th. Next slide. And then we ended that modified stage to January 31st, then changed capacity limits February 17, which probably was the most significant change in terms of adding risk to community transmission. Then end of vaccine passports March 1st, and the mask mandate, as Rob mentioned, was dropped early this week. Next slide. This is the Hamilton view in terms of hospital admissions, and you see that despite, for us, it looks like we are close to an all-time low. We are hovering around that for 4 weeks now. A little bit of an uptick this week when we are looking at the 7-day average, then last week and the week prior, but relatively stable since. For us, it's comparable to where we were in mid-September 2021, because as you may remember in Hamilton, we had a relatively significant Delta wave in contrast to some other communities in Ontario. Again, comparable to March 2021 or end of December 2020, similar to the provincial view. Next slide. ICU admissions, that was yesterday. Today, it's another nice drop to 164. So the ICU admissions in the province continue to decline, and we are currently in the ballpark that we've been throughout summer last year. So that's certainly good news, and we are in a much better situation than we've been in March last year before that quite brutal spring wave that we had to go through. Next slide. Hamilton-wise, ICU admissions, yeah, we are ticking up again, but this is 2 patients compared to last week, so it looks like a lot. It's not that many. Again, comparable to where we've been throughout summer. The lowest we've been since December 2020 was actually December 2021 before the Omicron wave hit. We've been higher throughout summer than this. Again, we certainly expect, and I will come back to that, this to pick up a little more over the weeks to come, but it should be manageable, and that's the term you typically see for the spring wave. Next slide. Big question that always comes up, what about Omicron BA2, that sub-lineage that's taking up speed, and just summarized in one slide what we, I would say, believe we know at this point of time. Again, science can always change, but what we believe at this point is that it's likely as virulent as BA1 or BA11, which is the sublineage that resulted in our Omicron wave in January. So similar to the original lineage, which is still named the Wuhan lineage, milder than Alpha and Delta. It's more transmissible, it seems, than BA1 or BA11, probably a short incubation period as well, which gives it a benefit over BA1 and BA11, and that's why we see the uptick. In contrast to Omicron BA1 and BA11 versus Delta, it's not that there's more of an immune escape, and that was probably one of the main factors that resulted in that quick overtaking by Omicron over Delta, was the fact that it had that immune escape, that our vaccines didn't work as well anymore against Omicron as they did against Delta. There's significant cross-immunity, it seems, between BA1 and BA2 and vice versa. So immunity from vaccines and recent BA1 infection will reduce risk of infection for BA2 as well, and in particular protect you from severe disease. Highest risk for severe infection or any infection, obviously those unvaccinated and no previous Omicron infection. Those at lowest risk for severe infections are those who had been vaccinated plus had a previous Omicron infection. And just a reminder again, only because you have had Omicron doesn't mean that you shouldn't get vaccinated. The combination of both is what provides the best protection moving forward. Next slide. This is a busy slide showing you those different lineages and sublineages. To keep it simple, Alpha was there, the blue wave at the left-hand side last year. Then Delta took over in the second half of 2021, and Delta is these 5 sub-lineages that you see here with different colors, but in the week that I entered it here, week 37, it was 100% Delta. Alpha was pretty much gone. And as you can see, it took a couple months for Delta to fully take over from Alpha. And then came Omega. Omega was first orange, which is BA1, and then yellow, which is BA11, so a slightly different sublineage. And it took Omega, well, basically a couple weeks to pretty much get rid of Delta. So a huge difference in terms of how quickly it could transmit compared to Delta. BA2 at the upper right corner is increasing, and we all expect BA2 to take fully over the next weeks and months because it does have a benefit in terms of transmission compared to the other 2 sublineages that we currently have. But you can see that it already took it, this goes until end of February, 2 months from BA2 to get to 70% of so-called market share of all the COVID infections. We might be sitting at around 50% now by end of March. So it may be the predominant lineage already, or will be within the next couple of weeks. All of this being said, what you can see is it takes longer for the takeover, which also means that it will not have the same effect as Omicron had when it took over from Delta. Next slide. At least that's our best guess at this point. How do BA2 Omicron waves look like? It really depends on how well vaccinated your population is. This is Hong Kong and New Zealand, 2 countries that pursue the COVID-0 strategy pretty much throughout, which wasn't sustainable anymore with Omicron, but they were hit by BA2 as their first Omicron wave. On the left-hand side, Hong Kong, where only 66% of the over 80s, well, 2 out of 3 of over 80s were unvaccinated. I have to put it that way when Omicron took off. In blue, you see the case numbers. In red, you see the number of deaths. Case fatality rate is 4.7% in Hong Kong. So almost 5% of confirmed cases passed away with COVID. While in New Zealand, where you have only a very small proportion, 2% of over 80s unvaccinated, you see very little red compared to Hong Kong, a case fatality rate of 0.1%. So only 0.1% of all confirmed cases passed away. So again, how you go into the Omicron wave and how it turns out really depends on your vaccination status, immune status at large to determine. Next slide. And yeah, just showing you this again, I showed you this repeatedly. Yes, with Omicron, preventing COVID-19 cases took a significant hit, and we are on average about, we have a vaccine effectiveness of maybe 40% at this point with 2 or more doses, higher with 3 doses than with 2 doses when it's about preventing cases. But once you're looking at hospital admissions and ICUs, there's still a huge, huge benefit from being vaccinated or not being vaccinated. Going back to the point, get vaccinated if you haven't done so. In this audience, I expect everyone to be vaccinated at this point. Next slide. So, crystal ball. That was the crystal ball from beginning of February. And I know I criticized this model multiple times because I didn't feel like this is how it will turn out, but that was first and foremost my gut feeling based on what we've seen in other countries that earlier went through an Omicron wave. And you can see I added with black here how the wave actually turned out in terms of hospital admissions, much better than even in the best case scenario, which is good news for us. Next slide. This is the updated provincial prediction here from 1 week ago. And again, I added in black the current trajectory of hospital admissions. And to me, this has a lot of face validity. I think most of us expect that we will see a spring wave. Here, the peak is expected to occur end of April, beginning of May for hospital admissions. And it's about a 50% increase to where we've been last week in terms of how many patients in hospital, which would be a manageable wave. As I said, this looks about of what most of us would expect. Hopefully it turns out to be true this time around because this is, as I mentioned, a very manageable scenario. Next slide. In terms of ICU admissions, again, the old models first here, and as I've previously shown you, we continue to decrease and are at well less than 200 ICU admissions at this point of time, while the model would have predicted to stay close to 300 at the lowest point and then going up again. So again, good news for us. It turned out to be much better than what had been expected back then. Next slide. And these are the updated models here, again, giving you a range from continue to decline and then basically a flat line until it continues to decrease after the second part of May, I would say, versus the scenario that would expect another increase into the range of roughly 300 patients in the ICU, which is where we've been back at end of February, so roughly 4 weeks ago. Again, I expected, that it will go up, but hopefully not worse than what you see predicted here. Next slide. The Hamilton predictions here, first hospital admissions, and again, I added the black line here. We are pretty much following the predicted model here, which is this scenario that assumes a resurgence, while S2, the light blue, would assume no resurgence in spring. So it looks like, yes, we are on the trajectory to see that resurgence. Again, if it turns out to be the way as it's modeled here, very manageable from a hospital perspective, it would mean that we would add another 50% of daily hospital admissions with COVID patients at peak, which here is expected to be earlier than in the provincial models predicted to happen in the next 3 weeks. Next slide. This shows you the the age stratification of hospital admissions. The majority of hospital admissions are expected to be in the 60 to 80-year-old age range, followed by the younger population, 20 to 60, obviously mostly the 40 to 60 and less the 20 to 40, but that's not further stratified here, followed by the 80 plus population, which A, is a smaller proportion of the population, and B, very well vaccinated with third and even fourth doses at this point of time. We don't expect anything significant in terms of pediatric admissions in the next weeks to come. Next slide. ICU admissions, here again, expecting an increase by roughly 50% to where we've been a couple of weeks ago. I added in black how it looks like, and on the next, which is my last slide, you will also see how it actually looks like for Hamiltonia specifically. So next slide, please. Every bar here is one admission, and you see that we had a time period of roughly 10 days with no Hamiltonian requiring admission to the ICU with COVID. Now we've had a couple of cases over the last 4 or 5 days. So that's the uptick that you see at the bottom as well. But again, compared to what we went through in January, we are expecting a relatively mild increase, but again, expecting an increase at this point of time. So all of this being said, there's lots of uncertainty as in all models as previously. What we see or what we expect to happen is very manageable to compare to what we went through in January. We don't expect any major policy changes over the next few weeks. Maybe we will see that we will turn back universal admission testing if our lived experience suggests that that might be of potential benefit, but not planning to do so within the next week, I would say, and see how things will turn out. The other question that comes up, well, what about relaxation of policies? Kristen just mentioned the relaxations in terms of visitors, which we felt comfortable doing. In terms of PPE, we don't expect to do any changes until we are out of this spring wave. And probably the first relaxation will be no longer to require eye protection for contact with unmasked patients. But other than that, pulling through with what our current measures are in the hospital, and then reassess that in May and come June when things should be slowing down. Over to you, Aaron. Thank you.
Thanks very much, Dominic, for the update today. Very informative. Okay, so next up on our agenda around unblocking our name and number at HHS is Lucas Milanovic, our Director of Urgent Ambulatory Care. Lucas, what do we need to know on this topic?
Thanks, Aaron. Really appreciate the opportunity to come and speak, provide a bit of an overview of this change. Obviously, I'm hoping and thinking it will allow us to positively connect with our patients in a more meaningful way. And that change is that as of April 7th, HHS will be moving towards unblocking of our name and number, which will be obviously very positive in how we connect with our patients. Reasons for the change are multiple. You know, obviously, as we move through the pandemic and for other reasons, we've increased the need to connect with our patients through phone. And so as you see, 15% increase in virtual care. Patient and provider feedback, specifically during the course of the pandemic, I think, you know, for a lot of reasons, we heard that the blocking of our ID was a challenge for folks to pick up the other end of the line. So for that reason, really a catalyst for this change. And of course, you know, understanding that other hospitals have gone this direction as well, and that it's seen in that positive light as well has really been encouraging. What we'll show for folks, just as an awareness, is the phone number there that's presented, and it'll say Hamilton Health Science or Hamilton Health Sci. For areas like in West Lincoln where this or unblocking had already occurred, there will be no change, and still will follow the current name and number. Specific to the Juravinsky and St. Peter's, who had a number showing, the number will still remain the same. The only addition will be that it will say Hamilton Health Sci in addition. And, you know, obviously all of this was informed by the engaging of stakeholders across the site. And based off of that feedback, there are only 2 areas that will remain blocked, those being the Sexual Assault and Domestic Violence Clinic and the Special Immunology Services Clinic. And there'll be additional information that'll be made available on the hub, and they'll inclusive of an FAQ. It'll be up on the hub, as I mentioned, in short order with this change prior to April 7th go live. And lastly, before I hand it back, obviously, really a privilege to be here to provide an overview of this change, but it's really the culmination of a lot of hard work of a very focused group, and that group being Ashley Dent from Privacy, Julie Matthews from the Virtual Care Operations team, Leslie Lamont for her work in public relations, and Lori Monahan from telecommunications. Without those folks, for sure, this change that perhaps has been talked about for many years across the organization would not have been realized. So recognition there, and thank you. With that, I'll hand it back to you, Aaron.
Awesome. Thanks very much, Lucas, and to the team for making that happen. Okay, so next up on our agenda, Dr. Barry Lum, our executive lead for Project Odyssey. Barry, we're just about to have that 60-day GLRA. What do we need to know?
Thanks, Aaron. Hi, everybody again. Thanks for the opportunity to give you a brief update. We'll all be, of course, very familiar with this slide by now, which shows our journey, and we are well into phase 4. And on the next slide, as Rob pointed out, as of today, we are 71 days from our go live. The amount of work that's happening to get us through and ready for the go live is really quite staggering, both on the Odyssey side of the house, but also the operational side. And you know, the organization has really rallied to the cause to help us get across the finish line. Next slide, please. So just a couple of slides about high impact workflows. Many of you will have heard this term now, another acronym, and it describes circumstances where there is a significant shift in the way we will go about our care as we move from our current state into the epic world. And we have identified a number of these, 20 of which, 21 actually, of which are considered to be enterprise-wide or corporate-wide high-impact workflows that need to be addressed to allow us to be able to go live and to mitigate risk as much as we possibly can, so that we can, on day one, provide the most effective and safe care for all of our patients. The team has done an amazing amount of work so far, and I would encourage you to go to the hub, click on the Odyssey site, and then click on the area that describes the high impact workflows. This is being constantly updated and defines each one of these and the work that's being done to help everybody feel comfortable that we're ready to go when June the 4th comes along. Next slide, please. One of the most important of these for the organization in terms of patient safety is our move across all of the sites now to have barcoded medication administration. And what this really means is that we will be able to provide the safest way to provide medication to our patients and to ensure that we check every time a medication is given to a patient. So it'll be a process of scanning at the bedside prior to the medication being administered, confirming that it's the right patient, the right drug, the right dose, and that we're doing it according to the planned schedule. There will be circumstances where some medications will actually require dual sign-off to help further increase the safety. And that terrible and terrifying paper MAR that we're all so familiar with will go away, and we'll actually feel confident that we know what we've done every day in drug administration. Next slide, please. A few comments about training. You've heard me talk about this over and over again. Super user training started this week for those all those folks who are going to be providing us super user supports at Go Live, and our in-class training starts on April the 4th. two important points. One is that you do need to complete your e-learning before you arrive for training. Absolutely essential, and really to give you the opportunity to start to get a flavor and hopefully some excitement about what the EPIC world looks like and what we call hyperspace and so on. But it's also critical that you come not only prepared, but on time and prepared to stay for the entire session. These are absolutely mandatory, and we really want you to enjoy but also satisfactorily complete your training. There are two sites for training. One is epictraining@hhsc.ca. That's an email address, of course. That's for what we call the non-provider side of the house. And then for the providers, physicians, nurses, physicians assistants, and so on, it is provider epictraining@hhsc.ca. We would really encourage all of our leaders to take the opportunity to touch base on the dashboard, find out where you're at, and of course, encourage completion of all the registration if you possibly can. Next slide, please. What's coming up? So as Aaron mentioned, on April the 4th, we will be doing our 60-day Go Live Readiness Assessment. We are going to do this off-site, and we would encourage as many of you who are invited to these sessions to join us off-site if you possibly can. These are critical steps towards understanding the organization's readiness for June the 4th. There will be a 60-day GLRA. You'll start to hear more about something called patient flow days. You'll hear about an organizational readiness day, workflow dress rehearsals, and of course, the user setting labs for all of the physicians as they go about completing their training. Come May, we'll have our 30-day GLRA, and you'll start to hear more and more also about something called shadow charting, where it'll give you an opportunity to touch the system, see what it's going to look like, ask your questions. And the last slide, again, of course, is our finishing slide for all of these updates. Please don't hesitate for a moment to reach out to us at Odyssey at hhsc.ca. And that's it for me, Aaron.
Awesome. Thanks very much, Barry, for that update this week. Okay, next up on our agenda is our Director of Employee Labor Relations and Human Rights, Tiffany Roblin, to talk a little bit about what we need to know and how we maybe need some, those who are needing support around the crisis in Ukraine. Tiffany, what do people need to know?
Thanks, Aaron. A brief but very important update today. We know everyone is likely aware of the war and humanitarian crisis ongoing in Ukraine. Our Employee and Family Assistance Program, Homewood Health, has many resources available on their website, including information and support on coping with and recovering from traumatic events. Our EFAP services are available 24/7 for folks to call to access mental health supports if needed. You can learn more about our EFAP and the resources they offer on the hub. Their number is also on the slide here for you. In response to staff needs for support, Michelle Cassidy, who is our Healthy Workplace Coordinator in the mental health space, as well as the Human Rights and Inclusion team, have also created space for staff, physicians, volunteers, students to gather in a Zoom environment to share and support one another. This is a space for peer support and connection. It is a space where we can come together and share the impact of what is happening in Ukraine personally and collectively. These spaces will be offered at 2 dates and times in the hopes that these offerings are inclusive for folks working different shifts at HHS. The first Zoom space will be on Wednesday, March 30th from 8 o'clock to 9 o'clock p.m. And the second space will be on Thursday, March 31st from 2 o'clock to 3 o'clock p.m. in the afternoon. If you would like to participate in one of these experience sharing spaces, please reach out to the Human Rights and Inclusion team at inclusion@hhsc.ca or Michelle Cassidy. Her email is there again for you on the slide. And please keep your eye on the hub for additional resources designed to offer support for folks who may be struggling as a result of this situation. And with that, I will turn things back over to you, Aaron.
Okay, thank you very much for that update. Just a quick reminder to everybody that should you have any questions that came to mind throughout the course of our presentations today, you can email those questions to hhsnews@hhsc.ca. That info is available at the hub as well, or if you have the opportunity to take it down right now. If you send a question there, you'll get an answer very promptly. So anything that was on the topics covered today, or of course, any suggestions you have for the town hall, the content that's being covered, the format, etc., feedback is a gift and always welcome. So thank you. Okay, next up is our celebrations. Certainly one of the more fun things that I get to do in a given day is to read out celebrations that are typed into our chat forum. And you can also, if you wish, give your celebration live. If you'd like, you can raise your hand in the participants forum and we'll call on you to give that shout out to whomever or whatever you think is deserving. It's a great opportunity to talk about colleagues, things that they've done, exceptional achievements they've received, someone who might be retiring or taking on a new role. Maybe there's a team that you'd like to talk about, or maybe an experience you've had at work. We'll just leave that open for a minute. So the chat forum is now open to type those in. Kirsten Kroll, I see you have a hand up. What would you like to celebrate today?
Hi, thanks, Aaron. Yeah, we always like to call out our different professional groups who have recognitions during various months. So we're just coming to the end of Nutrition Month. We're recognition of our dietitians and dietetic assistants. So way to go, gang. And Pharmacy Month, and I know they've got some awards coming up. And then Child Life Month as well. And headed into April is Medical Lab Professionals, the week of the 10th, and Volunteer Week's coming up as well on the 17th. But I just wanted to also recognize or just mention for folks who are online, the Nursing Week is coming up in May. We actually have Awards of Excellence nomination process open right now as well, up until April 1st. So have a look at the hub. There's some interesting categories that people can submit to for individual recognition, but also team award as well. So have a look at the hub, but the deadline for that is April 1. So it gives us a bit of time to make sure that we can review all these applications, of which we usually get about 60, but it would be great to see that double up. So thanks very much.
Thanks very much, Kirsten. I see one here in our chat forum. We have from Emmeline Gregorov. Shannon and I would like to give a shout out to Michelle Cassidy for always being there to support staff and for generally being awesome. Well, there you go. That's good. Thanks very much, Emmeline, for that. Sharon, I see you have your hand up. What would you like to celebrate today?
I do. Thanks, Aaron. And I really wanted to call out our staff over at the Satellite Health Facility, the newest addition to our collection of hospitals within the family of HHS. And a lot of work has happened in a very short period of time within the Satellite Health Facility, and they've done phenomenal work to get up and running so quickly and really respond to the needs of the acute sites. And it's a great team over there working very hard. So just wanted to give them an explicit shout out.
Awesome. Thanks for doing that. I see Elizabeth has a hand up. I know sometimes people put that up in error, so I'll just read one out and then I'll come back to you, Elizabeth. If you do have your hand up for a shout out, we'll call on you to deliver it at that time. Another one from Emmeline, I'd like to recognize the International Day for the Elimination of Racial Discrimination was on the 21st of this month, and Trans Day of Visibility is coming up on March 31st, both important recognition days for sure. Thanks for that shout out. From Morgan Richardson, a shout out to Sarah Thompson in OD for facilitating a great team well-being session with our multi-site screening team this week. Thanks very much, Morgan. I see Elizabeth, you have a hand up again. If you want to go ahead right now, you can give your shout out. You just have to unmute on your end.
Hi, can you hear me?
We can hear you. Go ahead.
It's actually kind of, and I don't know if it's an appropriate place to say this, but I'll say it anyway and you can let me know. So the first one is a recognition actually of all those who've been redeployed over the last, 2 years, but certainly this last redeployment. I myself have been redeployed and it certainly was immensely difficult, this one more so. So I want to acknowledge all those who have been redeployed. I also, in an adjunct to that, is recognizing that the recognition is great, but there's been some damage done with all this redeployment and certainly the morale and psyche of a lot of us. And wondering if there's going to be any kind of opportunities to reconcile some of this within HHS.
For sure. Thank you for that and for the question. So maybe what we can do is we can look to address that topic in more detail at our next town hall. We don't have an opportunity to respond right now, but it's a great thing that you've raised and certainly want to make sure that that is absolutely addressed. A very important thing to point out. And thanks for putting up your hand and making that shout out and for making that comment today. Important that you did so. So thank you. I also have here in our chat forum from Carrie Lynn Meyer, our urgent care center team, excited to be reopened today. That's awesome. Thanks very much, Carrie Lynn. From Paul Sandor, just a nice. You know, sometimes it's just nice to hear nice. Thanks, Paul. From Erica Casperson, all the staff who were redeployed to EHS and provided such awesome support. Thanks very much for that, Erica. Okay, well, I think we are reaching the end of our shoutouts. One more here coming in, late breaking from Kimberly. Big thank you to and shout out to the interim centralized recruitment team for their amazing collaborative team effort to support our recent HHS virtual nursing career fair held on March 3rd. It was a successful event. Thanks very much for that, Kimberly. Okay, well, I think we're closing in on the end of our celebration. So Rob, I'll leave it to you for final remarks. Thanks so much, everyone.
Thanks, Aaron, and good job as always. So I think mostly good news coming out of today. Certainly the numbers that we're seeing in the hospital of COVID patients are coming down, so that's great. And if Dominic's crystal ball is reasonably accurate, while we may see some increase, at least the best intelligence we have at the moment is that it will not be on the scale of the kinds of waves we've seen in the past. So I think that's also great news. Nice to see all of those redeployments being reversed and people managing to make it back to their home units. So all very positive. Would continue to encourage folks to continue to be prudent in their actions as they go out and about their affairs in terms of just being careful, knowing that the virus continues to be out there. So thanks all for attending today, and we'll see you again next time. Cheers, everybody.